Welcome to the Deep Dive, where we cut through the noise to bring you the most essential insights. Today we're digging into a system that's, well, fundamental to perioperative care, the ASA Physical Status Classification. We all assign these ASA scores constantly, right? But how often do we really stop and think about its origins, its limitations, and how it actually impacts patient care and even things like hospital resources?
That's exactly right. The American Society of Anesthesiologists Physical Status Classification System, ASAPS, it's a tool we use every single day. But maybe some of our usual ways of thinking about it are missing some key context. Understanding its history, its nuances, and where it, well, falls short can really sharpen our clinical judgment.
Yeah, and how we talk to patients and colleagues, too. We've gathered quite a few sources for this, the ASA's own statements, some historical papers, plus newer research on how it's used, its pitfalls, and its connection to outcomes and costs. Our mission today isn't just reciting the categories. We want to unpack why this system matters, its real value, and how you, our fellow medical pros, can maybe use it even more effectively. Okay, so let's start right at the beginning. We use these ASA scores all the time, but where did it actually come from? It's maybe not what you'd expect.
It's actually got a pretty interesting backstory. The system was introduced, believe it or not, back in 1941. It was a committee of three physicians, Meyer Sacklad being a key name there. And their first goal, the main thing they wanted to do, was figure out a way to collect statistical data in anesthesia.
And here's a fascinating bit for us as clinicians today. They initially tried to figure out how to quantify operative risk, but they pretty quickly decided that was, well, impossible. Back in 1941, can you imagine?
Exactly. They were quite insightful, really. They concluded it'd be much more practical and reliable to just classify the patient based purely on their physical status. The core idea was creating a kind of common language, so you could compare patient outcomes by separating the effect of the surgery from the patient's own condition beforehand.
Ah, okay. So it's always meant to be about the patient's inherent health, their physiological reserve, not the specific operation.
Precisely. It was never intended, at least initially, to be a standalone predictor of surgical risk.
Right. So the ASA officially adopted a five-category system in 1963 and then later added a sixth. The definitions we use now, with all the examples for adults, kids, OB patients, were last updated December 2020. Most of us could probably list the six categories right now.
We probably could, and what's really lasted is how simple and widely applicable those core categories are. Just to quickly recap. ASA 1, a normal healthy person. Pretty straightforward. ASA 2, patient with mild systemic disease. ASA 3, severe systemic disease. ASA 4, severe systemic disease that's a constant threat to life. ASA 5, a moribund patient, not expected to survive without the operation. And ASA 6, a declared brain-dead patient, organs being removed for donation.
And then there's that key modifier, the E. That adds another layer, right? You see ASA 3, ASA 4E.
Right, the E is crucial. It stands for emergency surgery. The definition basically means that any delay in treatment would significantly increase the threat to the patient's life or, a limb or body part. So like a class 5 patient, they're almost always going to be a 5E. By definition, they're dying without that immediate surgery.
Makes sense.
But class 6, that's just class 6. Organ retrieval is always urgent, of course, but the urgency is about the donation process, not an emergent threat to the patient's life since, well, they're already deceased, so no E modifier there.
Okay, that clarifies the E. Now, one thing with any classification in medicine and ASA is definitely no exception, is subjectivity, right? My mild might be your moderate.
That's a huge point. It's really critical. Sacklad, in his original paper, actually included examples specifically to try and get everyone on the same page to encourage uniformity. But interestingly, for a while, the ASA didn't continue that practice, and that actually led to more confusion, more variability between different providers.
Oh, really? That seems counterintuitive.
It does, doesn't it? But thankfully, they've since added approved examples back into the official definitions. And those examples are incredibly helpful for consistency, especially when you're trying to learn the system or classify those borderline cases.
Let's touch on some of those examples, maybe not just list them, but highlight where the discussion often happens, those gray areas, like ASA2, mild systemic disease. This is where we often put current smokers, maybe social drinkers, obesity with BMI 30 to 40, and pregnancy. That's ASA2 as well. Not a disease, obviously, but the physiology is so different, it makes sense classification-wise. Well-controlled diabetes or hypertension, mild lung disease too.
Exactly. And that's often where you get the first kind of blurry line between ASA2 and ASA3. ASA3 means severe systemic disease, usually with real functional limitations. So think poorly controlled diabetes or hypertension, COPD that actually limits what they can do day to day, or morbid obesity that's BMI 40 or more. Also, a history of something serious like an MI, stroke, TIA, or stents if it happened more than 3 months ago that puts them in ASA3. The key words are often poorly controlled or substantive functional limitation.
Right, the functional limitation part seems key for distinguishing 2 from 3 sometimes.
It really is. Then you get to ASA5. Now we're talking severe systemic disease that is a constant threat to life. This is where a recent event lands MI, stroke, TIA, stents within the last 3 months, or ongoing problems like active cardiac ischemia, severe valve issues, or really acute life-threatening stuff like shock, sepsis, DIC, that's disseminated intravascular coagulation. The threat here is immediate, ongoing.
Exactly, serious stuff.
Absolutely. And then ASAV is that moribund patient, the person who, frankly, isn't expected to make it without the surgery. These are the really critical situations: ruptured aneurysms, massive trauma, big intracranial bleeds causing pressure. These patients are often right on the edge. Surgery is the only hope.
Okay. To make this really stick, maybe let's walk through a couple of those clinical scenarios you mentioned, especially the ones that kind of test the boundaries.
Good idea. Let's take that 20-year-old healthy college athlete, elective ACL repair, non-smoker, normal BMI. That's about as clear an ASA1 as you can get.
Easy one. Okay, what about that 19-year-old student, emergency surgery after a car crash? BMI 29, so not obese, and just has some well-controlled acid reflux.
That would be an ASA2D. The E for emergency is key. And it's worth repeating. Having a full stomach dramatically increases anesthetic risk, definitely changes our plan, but it doesn't change the ASA physical status score itself.
Good point. Okay, trickier one. 30-year-old woman, elective ovarian cyst removal. She's anemic from heavy periods, has type 2 diabetes, but it's managed with metformin, but her BMI is 42.
Right, so even though the diabetes seems reasonably controlled on oral meds, that BMI of 42 puts her squarely in the morbidly obese category. That alone bumps her up to ASA3. That BMI cutoff is a common discussion point.
It really is. Okay, now a complex one. 70-year-old woman, emergency appendix surgery, 100-pack-year smoker, poorly controlled COPD, morbidly obese, BMI of 46, insulin-dependent diabetes. And the kicker, gets short of breath just walking a few steps.
Yeah, that one brings it all together. You've got multiple severe, poorly controlled diseases, plus that significant functional limitation, shortness of breath with minimal exertion. That's a definite ASA4E, no question there, really.
Okay, and the extreme case. 55-year-old man, massive trauma, lacerated aorta, comes in basically in cardiac arrest, needing tons of blood products.
That's ASA5E. He's moribund, not expected to live without that immediate life-saving operation. Stark reality.
And finally, just to cover all bases, the ASA6. The 25-year-old declared brain dead. Family agrees to organ donation.
Exactly. A distinct category for a very specific, critical situation in our field.
These examples really help solidify it, I think. They show how we take those definitions and apply them, sometimes having to weigh different factors. It's our common language.
It really is a fundamental part of how we communicate.
Okay, so we've got the definitions, the history, the examples. But now the big question, so what? Why does this matter beyond just assigning a number? What's the real impact on patient care, maybe even on the healthcare system? This is where it gets really interesting.
Right. This is the crucial part. The ASA classification is so foundational because it gives us a standardized way to quickly size up and communicate a patient's overall physiological state before surgery. It helps guide our clinical thinking, gives us a sense of their physiological reserve, and as you alluded to, it even plays a role in things like healthcare billing in the U.S.
It sounds so simple on the surface and so useful, which naturally makes you ask, are there downsides? What are the limitations we really need to keep in mind when we use it?
Absolutely. And ironically, its strength, that simplicity, is also kind of the root of its biggest problem: misinterpretation. Even though SACLAD and the original committee were clear it was about physical status, the ASA score gets misused all the time. Hospitals, quality committees, sometimes even lawyers, they treat it as if it's a direct, standalone predictor of operative risk.
Which it was never designed to be.
Exactly. That's such a critical point that often gets lost. The original creators knew you couldn't easily predict overall risk like that.
So that's a major conceptual pitfall. What else limits its usefulness or requires caution?
Well, another big one is inter-rater variability. It still happens. You and I might look at the same patient, especially a complex one, and come up with different ASA scores. Maybe we weigh age differently or anemia or exactly where the line is for obesity or functional limitation. And this variability can be even more pronounced when, say, non-anesthesiologists are assigning the score, maybe with less clinical context.
Yeah, I can see that. Have you run into cases where that difference in assigned score became a real issue or point of discussion?
Oh, definitely. You see it with things like diabetes control. Is well controlled on 3 meds really the same physiological state as well controlled on diet alone? Probably not, but they might both get slotted into ASA 2 or 3, depending on who's looking. Or that BMI borderline we mentioned, 39 versus 41. Technically different ASA classes, but is their actual perioperative risk that different based on those few pounds? These are the nuances we grapple with.
And beyond the subjectivity, the system itself just doesn't capture everything important, does it?
No, it absolutely doesn't. Things like extremes of age, a tiny neonate, or a very frail 95-year-old, they have different physiological responses, but age itself isn't directly in the ASA score. And critically, it doesn't account for specific major risk factors like a known difficult airway. That's huge for us. Or a patient who refuses blood transfusion, like a Jehovah's Witness. These things dramatically alter risk, but aren't reflected in that single ASA number. We have to add that layer of judgment.
Right. So putting it all together, its strengths, its weaknesses, its history, what's the bottom line on its clinical significance? How should we as practitioners really be using it day to day?
I think the best way to view it is as a general conceptual framework for thinking about perioperative risk. It's a starting point, incredibly useful for guiding individualized management plans, but like we've been saying, it doesn't and can't correlate perfectly with overall operative risk all by itself. Think about it. An ASA Class 3 patient having cataract surgery with just eye drops versus that same ASA 3 patient having a massive chest surgery like an esophagectomy.
Worlds apart in terms of overall risk.
Totally different risk profiles, even with the same ASA score. The procedure matters immensely.
Or even two patients with the same ASA score, say ASA-5, with similar diseases.
Hmm.
But one is stuck in a wheelchair, really deconditioned, and the other, despite their illness, still manages to walk a decent distance every day.
Exactly. That functional capacity piece is often missing from the raw score, but tells you so much about their resilience. The ASA score might be the same, but their ability to withstand the stress of surgery is likely very different.
Okay. But even with all these caveats and limitations, the score does still tell us something important about outcomes, right?
Oh, absolutely. Despite the nuances, there are clear, strong correlations. That study you mentioned on laparoscopic colorectal cancer surgery, it really showed this powerfully. They found that higher ASA scores, especially hitting ASA3, were independent predictors of more postoperative complications. The rates went from about 22% for ASA up to 28.5% for ASA2, and then a big jump to 38.2% for ASA3.
Wow, nearly double the complication rate going from ASA1 to ASA3 in that group.
Yeah.
That's significant. And not just complications, right? There was a cost element too.
Yes, definitely. The same study linked higher ASA scores directly to significantly higher total hospital charges. Patients who were ASA1 averaged around, $10,700. But ASA3 patients averaged closer to $14,000.
That's a big difference per patient.
It is, and it makes sense, right? Higher ASA patients often need longer hospital stays, maybe more ICU time, more interventions. It reflects the increased burden of care their underlying health necessitates.
That really drives home the connection between the patient's baseline health, as captured imperfectly by ASA, and the actual resources needed. It highlights why getting the classification right and using it as part of a broader assessment is so vital for planning and communication.
Precisely. And this leads to a really practical point for everyone listening. If you have a patient scheduled for an elective surgery, and they're an ASA 3 or 4, getting an anesthesia consult early, well before the day of surgery, is so important. It allows time for proper workup, maybe optimizing their condition, better blood sugar control, tuning up their COPD treatment, whatever it might be. This can genuinely improve their outcome after surgery and drastically cut down on those frustrating last-minute cancellations because they weren't medically ready.
Good point. It really emphasizes the team aspect, getting everyone involved early for those higher risk patients.
It's all about better care coordination and communication.
So we've covered a lot of ground. From its somewhat surprising origins, remember, they gave up on predicting operative risk, to the nuances of classification and its very real, powerful implications, even if it's often misunderstood. The ASA physical status classification system is clearly more than just a number we assign. It's a dynamic tool, maybe imperfect, but indispensable when we use it thoughtfully, with critical thinking. It really shapes how we assess, prepare, and ultimately care for our surgical patients.
It really does. It gives us that initial framework to quantify physiological reserve, communicate a baseline health assessment, and that guides our decisions towards improving patient safety and hopefully their outcomes.
So as you go about your work, maybe dealing with your next ASA classification, here's something to think about. ASA gives us that snapshot of physical status. But what other factors, the ones maybe not captured in a neat score, things like resilience, social support, maybe even patient attitude, how much do those matter? And how can we, perhaps in the future, integrate those deeper, more personalized insights to tailor our care even better? Something to mull over until our next deep dive.